Welcome to a webinar on value-based payment for primary care and behavioral health practices. This is the fourth webinar in a series brought to you by Millennium Collaborative Care and community partners of Western New York. We're thrilled to be able to offer a candid and insightful interview with Dr. Raul Vazquez from the Greater Buffalo United Accountable Care Organization. Hi, Dr. Vazquez. Thank you for joining us today.
Hey, thanks for having me.
So what we would like to do is talk a bit about value-based care, and I'm pretty sure you don't need an introduction, but just in case someone just moved to Western New York and hasn't heard of you and some of the work that you've done, can you just give us a quick run through some of your bio, some of your highlights?
Well, when it relates to the Accountable Care Organization, we started as an IPA back in 2008, and I think that brought the doctors together because we knew healthcare was changing. And it was just tough to standardize things when we were all separate. So under that IPA system, in 2013, the care coordination entity came along, which is called a health home, which is GBON. And we used that with the IT informatics to form an accountable care organization in 2016. And from there, actually, we have a value-based agreement in our third year with Your Care. And that's what we've been able to accomplish.
Oh, that's fantastic. I mean, as you look back over the last 3 or 4 years here in Western New York, what do you see as some of your biggest successes and most important lessons learned as it relates to value-based care?
I think, it's sort of new. So I think for medicine, it's a change in medicine. And I know people don't like change, but I think change is really good. It's really looking at, it's hard to compare who's providing what kind of service to a member or patient, And I think with the value-based systems, you're able to kind of start to see how practices that are high efficiently, that are doing really well in quality metrics, and the ones that don't do well, and how to get everybody to the same level, and using the same types of workflows or protocols so that everyone's achieving close to the same type of metrics. Because when you get into the value-based world and you have contracts, you're in it all together. It's not just one section of the entity that does what they want to do. Everybody's has to have the same buy-in. Otherwise, you'll get hurt financially. We're in a value-based level 2 agreement. So that's, the next level from here is full global risk. And so, you working with teams, there has to be a lot of trust and transparency.
Oh, that's great. So sort of looking forward now, what do you see that you're working on now? So, kind of what's next for you as you think about value-based payment?
So, when we started with value-based, we did a level 1 agreement. What happened there is you were learning about the measures, you're learning about the shared savings. And that first year, we really wanted to focus on getting everybody on the same page based on the quality metrics, because it doesn't matter that you have shared savings. If your quality metrics weren't there, you're not going to get anything. And so what we ended up doing was really working on getting those quality metrics where we needed to be. And then the second year was really trying to go after the share savings, because the second year where we're in the value-based level 2, we were at $500,000 risk for that population. And so, if your medical loss ratio was above what you expected, then you were going to have to pay some dollars. So, the second year was more on the share savings component. The third year now, because we've actually added more risk to the contract, it's good because the quality metrics were we were good. And some of the quality metrics were like mammography, which account for 2 years, or colonoscopy, which accounts for 10 years. So once you get these done 1 year, they're almost like an auto credit for the following year. So now, we're focused on the quality metrics, just to kind of improve that. And just the game that goes with deciding what those are and the percentages that go along with that. But now we worked on more of the 5 buckets of costs, which are real important to kind of keep in mind, which was inpatient and ER. So how do we develop models around that to reduce that? Because at the end of the day, we end up saving some dollars. One of the buckets we did work on the first year was the pharmacy bucket. And we were able to change 8 drugs and really had about a $2.4 million savings just by changing drugs. Not something that was dramatic, as going from a brand to a generic, on a statin, a brand to a generic on a metformin for diabetes. So those things have an impact. And now what we're doing is getting into more deep and dive in terms of the PBM, looking at that aspect of it. But really, this year has been more inpatient and ER buckets, ancillary buckets we're looking at. And then the last piece I mentioned was the professional buckets, to make sure that we're going to have some increased costs there, and that's what you want. But you want the traffic going into a primary care model, away from what we just mentioned, ER and inpatient.
Just before we leave this topic, I'm curious how much of your work and how much in working at those buckets has really taken you, in a sense, outside of the primary care realm, and had you talking more to hospitals to really understand the cohorts, or talking to other entities, be that behavioral health providers or social determinant of health providers, in order to try to improve the performance on metrics?
Yeah, so, it's interesting because, some of these practices, especially in the Medicaid market, have always dealt with the social determinants of health in different ways. Urban, my practice, we had transportation back in 1996. We've always had it. So, that and value-based agreements now require you to have a social determinants of health kind of entity or a partner, which may be a CBO, community-based organization, or someone working in the space. And those could be, like you mentioned, not just transportation, but food, housing. And housing tends to be a bigger problem. But how do we work around that to really change the education level or the health literacy of that patient? And I think, everybody's talking about PAMs, but how do we take these patient-activated measures and really take it to the next level?
That's great. So now shifting gears a little bit and talking about medication-assisted treatment, and I see, if I'm not mistaken, that you have some things going in this area. So could you talk to us a little bit about medication-assisted treatment, what you're doing, and again, what you see next?
Yeah, so a couple of things that we're doing in this space. We partner in our value-based agreement with YourCare. They've been a fabulous partner in terms of an insurance company. It's never been the case with providers and insurance companies working this close. So we submitted for a grant, which had to do with the substance abuse entity, which opiate, as you know, is plaguing our communities. How do we design a different model of care? And we partner with Endeavor, which is a behavioral entity, to kind of not only, because a lot of people with substance abuse issues have that because of mental illness. They may be bipolar, schizophrenic. So, you can get them off the drugs, but if you don't manage the mental health, it's just not going to get better. So that's one of the pieces of what we submitted. The second piece was a different delivery model. Dent basically started using Suboxone injections on a monthly basis. And what we did was we wanted to take that idea and we become sort of the second player in the area to really manage that population differently, not just with the films or the pills. And I've been doing Suboxone for a while in terms of treating patients, but this gives you that injection once a month. So you're not chasing all these little papers and wasting a lot of time, and really focusing on connecting this patient to getting the right support structures and also getting the mental illness that they need to have under control. So that's one component of it. We're also working now, and this is where we applied for an innovative grant through the district to develop a telehealth nursing kind of system, where we're actually looking at individuals that have been high utilizers of the ER that we haven't touched in a lot of different ways. How do we bring them into care coordination? And if it's related to poorly controlled blood pressure, diabetes, heart failure, is putting like a Medicube in the system to assist the patients with med reconciliation. So if they're on 14 drugs, HIV, 14 drugs, you can actually put them in the system, and we're getting notifications that those medicines are the patient's taking them. And if they're not, we're deploying the people to make sure that, the patients understand how important it is to take these meds.
That's great. As you think about, because these webinars are going to be, heard by a lot of primary care practices and also behavioral health providers, I think this is a helpful opportunity for us to sort of share some dialogue with each other about, things that might be helpful within the next year or two for that other system to be providing. In addition to medication-assisted treatment, Are there other types of mental health or substance use service that you're really seeing at this point a really significant demand in your sort of view of the system?
Well, I do see it in a lot of different ways. One of the things that I think the platform for value based is being laid down in New York State just came out with a Medicaid update for telehealth is how do we develop the specialties for telepsychiatry, which can really help individuals in the home. And we're using our navigators to go out to the homes and really have interactions and be able to bring these individuals through a Skype for Business model, encrypted, 128 encryption, and having that communication take place, whether it's a specialty or behavioral. So that, especially things like teledermatology now, because the equipment's there. There's a lot of these things that we can kind of offset so they're not showing up within the boxes or coming into the offices for those services, or in some cases they don't even come to the doctor. So how do we move it out of a box into the people's community? So that's one of the areas that I find that this coming year 2019 is going to see a lot of growth and development. And in our value-based agreement, we're looking at bundles that allow us to really divert or change the way that patients are managed. So we're not looking at patients in terms of a ticket. If I don't get this and I don't do it. So how do you begin to do other things, even though you're not being paid for, but in the long run, the share savings, quality bonuses, and things like that are going to make up for it. So I think patients in the long run get better care that way.
That's great. Are there other areas that you see moving into telehealth with? I mean, there's certainly this month, the health department came out with new guidelines around telehealth. Some of the specialty agencies are really moving to that. In addition to looking at behavioral health and dermatology, are there other areas that you're looking at telehealth?
Oh, actually, absolutely. So, I mean, we're trying to do one of the pilots that we're working right now is a nurse-assisted triage system, so that if a patient does have it, we can send a nurse out or a PHM with a title care. We were the first in this state to use title care, which is a remote monitoring system that allows you to videotape sort of an ear exam, a throat exam, skin. You can take temperatures, lung sound, heart sounds, blood pressure, and weights, and get all that information transmitted in a system where the provider, let's say I've got individuals that are working after hours, and they can actually see and talk to the patient while the PHN's there and get access to this information and say, you know what, by the way, this is more of a sinus infection. So we're going to send we're going to e-prescribe the medicines and we'll have it delivered to you. Okay. That's one thing. Two is we do an exam. We find out, you know what, they have some bronchi, could be a pneumonia. Why don't you send them here to the after hours? We're going to infuse them, give them some IV antibiotics and manage it. While if it's someone that just, we don't know. This one shouldn't come to the after hours. We follow clear triages in terms of monitoring to find out where people need to go. This one probably needs to go to an urgent care, or this patient, needs to go to the ER. We can filter that because it's in our best interest to do that. But the players that we find may do really well with this area would be, especially I think the diabetic educators. I think that could be a real big thing with the diabetics in terms of better control. Asthma educators, we have a lot of asthmatic patients that are running into problems that we could probably utilize their expertise across the spectrum. So those are the areas. Besides your extenders, and it's I think psychologists and social workers are going to play an integral role with a lot of the stuff we do.
Oh, that's fantastic. Well, I'd like to thank you for sharing your time and insights with us today. We thank you for sharing what really sounds like very excited work that you're doing, and thank you very much.
Thank you very much.